Good afternoon.
It is exactly 14:30 and we are beginning this afternoon's session. And a warm welcome and sincere gratitude to all of you that connected in time, because we did the sound check much earlier. And I know we are all connected and we'll be able to observe the rules of connecting to the network without disturbing the session. I wish to introduce everyone who has come in. I see we have over 51 participants, others now, right now 60, and it will take a long time to introduce everyone. So sincere apologies for that. In the interest of time, I wish to introduce the two presenters for this afternoon. The didactic presenter is Dr. Patrick Lungu, our national TB program manager. We also have a case presenter from Choma General, Dr. Miliary TB, who will present a case a little later. So thank you for joining in.
Thank you very much, Dr. Chengamo.
Thank you, Dr. Lungu. And I wish to hear the voice of Dr. Miliary TB from Choma General. Dr. Nchimunya. All right, someone from Choma General, please get in touch with Dr. Nchimunya. We need him in, and he should signal when he is in. We do not wish to have headers when it comes to the presentation. Dr. Lungu, are you ready to start the session by presenting the didactic?
More than ready, Dr. Chengamo.
Thank you. I think in the interest of time, I know there will be a lot of discussion on this subject matter. I wish to allow you to go ahead with the presentation. Are you going to share the slides from where you
are? Yes, let me start. Just give me a minute.
Thank you.
I think you can do the slide share from your end because there are poor questions. I think they've been arranged in a certain manner. So if you could start sharing from your end. Is that okay?
Okay. In a moment, it will be up. Thank you.
Thank you.
All right, the slides are up, Dr. Lungu.
Thank you very much. So I think my opening statement to everyone is just to share with you that this is a topic that I take much delight in sharing, and that's the role of the radiology in TB diagnosis. There's been quite a lot of discussions on this particular subject matter, and I would like just to share with you what should be the normal practice with regards to radiology and TB. We can move to the next slide. So essentially, this is my outline of the presentation. We'll look through the principles of TB diagnosis, and then we'll look at radiology in TB diagnosis, radiological diagnosis of pulmonary TB, and radiological diagnosis of extrapulmonary TB, and what are the frequent pitfalls. Next slide. So I think to begin to help us discuss this subject matter, we have 3 poll questions, and our first poll question is, a chest X-ray is a cardinal diagnostic tool for TB. So the responses we expect is a true or a false. So Dr. Chengamo, you could guide on how we run the poll question. So that's the first poll question for today.
One moment.
Yeah.
Okay. Poll 1 is launched, and the question is: the chest X-ray is a cardinal feature or cardinal diagnostic tool for TB. And I see very interesting responses already, with 84% so far saying it is true.
Yeah, those are interesting responses. We'd like to see what the outcome of this poll question is.
Indeed,
And
we have 30 seconds to go.
yeah.
All right, end of poll. Those are the results. 85% think it is a cardinal diagnostic tool, and there's 15% that think it is not. We'll be guided as we move on. Thank you.
Yeah, interesting results that we are seeing from the first poll question. And good that there are two valid answers, and I think it makes the basis for this discussion.
Indeed. Sorry, I need to reshare.
On the left palette. Yeah, then you'll just go to next.
Over to you, Dr. Lungu.
Thank you very much. So I just want to share with you once again that Zambia has a high burden of TB, and we are among the 30 high TB burden countries in the world. And among those, we are 13th. I think this is one statistic that we should all work together to change the scenario. We should come out of this bracket of the 30 high TB burden country. And also to share with you that our burden of TB is driven largely by HIV and followed by undernutrition. We have other risk factors for TB, such as smoking, alcohol, diabetes, but to a large extent, the two main drivers is HIV and undernutrition. Then also just make sure I share with you that for us to stop the epidemic, we need to reach out to most of the cases, and we need to have the most diagnostic tools for us to pick up most of the TB cases. And that in itself also forms the basis why we are discussing today. Thank you very much. That's what I wanted to share with you in my introduction remarks. So the second poll question is, the chest X-ray is the most sensitive TB diagnostic tool, but less specific. So the responses we expect are true or false. So Dr. Nchengamo has started the poll question. So we expect you now to start responding to the poll question number 2. Dr. Nchengamo, please guide on how we move on this poll. Dr. Nchengamo, are you there?
Thank you, Dr. Lungu. Sorry, a little mishap there. I'm already receiving responses for the poll number 2, and it's in progress. And we have about 10 to 15 seconds before the end of the poll. And while I wish to welcome the co-facilitator, Dr. Kozia Ziambo, who is in the house in hub number 1.
No, good to see you, Dr. Chengam.
Good to see you.
All the way from Solwezi.
Thank you. All right, we end the poll here.
I'm anxious to see the results, Dr. Nchengamo.
Here wow. There's a big tug of war. The system has a little mishap. Let me try again.
Okay. You are doing to share the results.
Okay.
Share results.
So the question, chest X-ray is the most sensitive TB diagnostic tool, but less specific. There is 41% who think it is true and 59% who think it is not.
Okay, interesting results as well there. And I think it's a good choice that we chose this topic for today. So we're going to have a very good discussion. I hope at the end of the day, we'll have changed the scenario. So essentially, the principles of TB diagnosis, that TB affects principally the lungs. That's the first organ that it affects. Then this later on, if it's undetected, it starts to spread to other parts of the body. It can go as far as the meninges and affects the brain. And by that, it can actually cause TB meningitis. It can affect any organ, starting with the skin. TB can affect the skin, it can affect the heart, it can affect the abdomen. So we're going to learn a bit more on how TB goes by. So by and large, we would like that TB is confirmed microbiologically. By confirming it microbiologically, you are very certain and sure that what you are treating is indeed tuberculosis caused by Mycobacterium bacteria. And the other advantage of microbiological confirmation that it also gives you the drug sensitivity testing. So you are very certain that either you're dealing with drug-resistant TB or you're dealing with drug-sensitive TB. So that's the advantage of confirming confirming TB microbiologically. And using this method, you treat the patient appropriately. However, there's a fraction of TB that is difficult to confirm microbiologically. In our population, like I said in my introductory remarks, TB is driven largely by HIV. Patients with HIV have what we call pulse bacilli. And by pulse bacilli, we're essentially saying that they have low bacterial load in their sputum. So the chances of you confirming TB microbiologically is quite low. You will do your gene expert on sputum, you will do your culture. There is a huge chance that you're going to have a negative result. So I also want to mention to you that the microbiological means of diagnosis of TB are 3 of them. If anything, now we have urine lab that makes it 4. So the gold standard is TB culture. Then we have our molecular tests, which gene expert falls in there, as well as the line probe assay. Then traditionally, we've also used the light microscope. Now we have the fluorescent microscope. The newer diagnostic tool that has come up is where we are using urine for TB diagnosis, and here we are using the urine lab. So these 4 modalities give you microbiological confirmation of TB, and by and large, that's what we are promoting because it gives you the certainty. But also now the discussion we want to say there is, like I said earlier on, there are forms of TB that cannot be confirmed microbiologically, especially the extrapulmonary forms of TB, and that's what we're going to discuss largely here. And that in itself calls for clinical diagnosis, having a higher index of suspicion, and using your tools pretty well to arrive at a diagnosis. We can move to the next slide. So the question we should be asking ourselves during this session and answering at the same time is, does radiology have a role in TB diagnosis? The answer indeed, yes, and a very huge role. And we're going to take you through that there are certain characteristic features of TB that we see on many of the radiological tools. And the radiological tools that we are talking about largely is the chest X-ray. We're also talking about the chest CT scan. MRI also can be used. And also I'd like to just also share with you that an ultrasound can be used to diagnose TB. And lastly, an echo can be utilized to diagnose TB. So those are the things that I want to take you through. So the principles for TB diagnosis using radiological means essentially what, to a large extent, the role of radiology is largely in pulmonary TB, but we can still use it in other forms of TB, be it extrapulmonary as well. When you have TB meningitis, as we'll go through the slide, you realize that actually CT scan can be very useful in diagnosing TB meningitis. I think those are the principles I wanted to share with you in this slide. Next slide. So to a large extent, if we are going to use chest X-ray for TB diagnosis, and of which we have been using, there are certain times that a chest X-ray is going to come out normal, but someone may have TB, especially in HIV, those with severe immunosuppression. But what they also want to share with you that there are features that are characteristic, which we may also say that there are features that are pathognomic of TB. And these features are essentially consolidation, a cavitation, and TB by nature loves where there is oxygen. So in the apices, that's where there's higher grades and proportions of oxygen in the lungs, and TB would like to actually settle there. And this is why you see that in HIV negative, they tend to have cavitations in the apices, and it's because mycobacterium loves where there's a lot of oxygen. Pleural effusion and pleural thickening, by and large, all of us do agree that in our environment, yes, there are quite a lot of pathogens or organisms that can cause effusions, even conditions such as malignancies and the like, and heart failures and the like. But to a large extent, we can use effusion as a TB diagnosis, especially if it goes with other features such as weight loss and the like. But I also want to draw your attention to pleural thickening. This is something that we are not so good using. Pleural thickening in itself defines tuberculosis. There are very few other conditions that cause pleural thickening. I wish I had a chest X-ray that shows the pleural thickening. I think among my slides, none of the slides demonstrates pleural thickening. So I think in the next session or post this meeting, I will share. So pleural thickening can be used. Widening of the mediastinum, by and large, it's actually indicating that there are mediastinal nodes, and then also paratracheal adenopathy. A combination of any of the above could actually define TB. An enlarged heart, but that in itself is not very characteristic until you do echo. So a normal chest X-ray does not exclude TB. I want you to take that as a point to take home. Next slide, sir. So this is what we were referring to as apical cavitations in TB. If you look at the slide, I should have labeled them. So the slide that is on where the mouse is, that in itself is demonstrating the characteristic feature of TB. That's an apical cavitation, and this in itself is very characteristic. You can see that there is hypodensity, that is a cavity. And that's what is around, what is appearing as white around that, that is the cavity, that's calcification around the cavity. So this, when you see this and marry it with your symptoms, don't hesitate, start TB medication. And in the other X-ray on your right, what we are seeing there is also a cavity up there, and also a lot of calcifications up there, and that's an outside cavity above. And on the left side of the chest of this patient, Dr. Nchengamo put the case on the left side. There's a lot of calcifications above. So these two X-rays define tuberculosis. And I think even in this X-ray, we can see pleural thickening. Around the pleural area, what appears whitish, that is pleural thickening. And that's too as well defines TB. Thank you. Next slide. So this as well is just expressing or showing the apical fibrosis seen in TB. So there's a lot of fibrosis in the apical area in the left side. So this in itself defines TB. There's also something characteristic of TB. If you look at the diaphragm on the right-hand side, there's a bit of tethering happening there. And also the cardiophrenic angle there is not an acute one. There's an obliteration of the cardiophrenic angle, and this is due to fibrotic changes as well. So this in itself is another X-ray that shows the characteristic features of TB. Next slide. So I think moving on to extrapulmonary TB, what we've been discussing in the previous slides is mostly pulmonary TB. So like I said in my introductory remarks, any organ can be affected, and this can also occur in both HIV positive and non-HIV positive. To a large extent, it occurs in individuals with severe immunosuppression. And the common site for extrapulmonary TB is largely the lymph node, the meninges. Medially means actually wherever there's a blood vessel, that TB is there. Pleural, spinal, and pericardial. Not forgetting the skin. But then you cannot diagnose that radiologically. So that's why I did not talk much, include it in my slides. Next slide, sir. So pleural TB, by an extent, by and large, is an extrapulmonary TB. If we could just move to the slide that shows. And about the pleural TB, one of the things that you can do is that you could ensure that you swab the area where you think there is a pleural effusion, and you could do a diagnostic tap. If the fluid is straw-colored, in our setting, that straw-colored is due to TB. If it is pus that you've isolated from a needle syringe, that too is likely to be TB. But I would like you to subject the effusion to Gen expert as well as culture. Either it's an effusion or pus subjected to culture. And if they come out negative, if it is pus, continue the ATT, or if it's straw-colored, continue the ATT. I think here not much to say about it other than what we have said. We could go to the next slide. So these X-rays let's show the X-rays, Dr. Nchengamo. So the X-rays, if you look at the one on your left, that's a huge effusion. And that requires tapping. Not only ATT, it requires to be tapped to improve the breathing of the patient. And also this in itself can actually compromise the cardiovascular system because it's taking up a lot of space in the chest wall. And also what we are seeing in the left, in the X-ray on your right side is also an effusion on the left side of the chest of the patient. That too also requires tapping, not just starting the ATT. So these are the features of pleural effusion that we've been talking about. And when you see this in X-ray, that's an effusion. And what you actually see is an air fluid level. If you actually see in the left, in the X-ray that is on the left, what you are seeing there is an air fluid level. So when you see this, don't be short of any diagnosis. That's essentially an effusion. Air fluid level in the lung is purely an effusion, and pushing a needle and see what type of fluid is coming out. This may occur in heart failure, so be very good at distinguishing heart failure, effusion from heart failure, or nephrotic syndrome. Next slide. So miliary TB, I'm sure we are all very familiar with miliary TB. So this essentially denotes hematogenous spread of tuberculosis. And you can see this in the X-rays. You can see this on CT scan. You can see this on ultrasound. So setting out, this is why in my introductory remarks, I mentioned to you that ultrasound can be used to diagnose TB where you have it. So next slide. There are a lot of differentials for miliary TB, but in our setting, TB is the #1 cause of miliary picture. So this essentially shows as if there are millets in the chest. So you see white, small, dotted whitish lesions, and all spread across the lungs. You will not see that only part of the lung is affected. It's actually widespread across all regions and lobes of the lung. Next slide. So this is an interesting slide in that if you look at the chest X-ray, you may think that there isn't much in the chest. You can see a bit of whitish nodular patches, but not very, very characteristic. This could be at the beginning. But this is the same patient they did a CT scan and see what they saw. So essentially, the CT scan magnifies the smaller nodules and see the picture that is there in B. So a lot of millet or whitish nodular patches, which you couldn't appreciate on a chest X-ray. So this now starts to bring in the importance of a CT scan. In places where you have a CT scan and you're not so sure about the X-ray, please request for a CT scan so that you have a clear image and you treat the patient better. So that's a take-home message from this slide. Yeah, so now this brings us to our third and last poll question. An ultrasound as a role in TB diagnosis, true or false? Let's see if I've been able to deliver the lecture very, very well. I'm sure Dr. Foloshi, I was going to say that I'm sure Dr. Foloshi will assess my impact based on this question. And we'll see what we'll get from the poll question. Dr. Chengama, please guide us through.
Okay, I think the hub is frozen, but we can read the question. So the question from Dr. Lungu is, an ultrasound has a role in TB diagnosis. Is this true or false? I can see a couple of us are voting. Unfortunately, the hub is muted for some reason. A couple of us are voting. Is it true or false? Can you use an ultrasound to make a diagnosis of TB? I know only 60 of us have voted, but we are joined by 125 connections. Please, we need to see your vote so that Dr. Lungu can know what to emphasize on as he teaches. Can we use an ultrasound to diagnose TB? Is this statement true or false? Bear in mind that TB can be anywhere aside the lungs. It can also be in the abdomen. Do you think an ultrasound would be useful? So I'm going to end the poll. I can see the hub is back. I think they had a bit of a technical hitch. Dr. Lungu, please have a look at how people voted. 96% of the network felt that an ultrasound is useful, but there is a 4% you have left that need a bit of convincing on the role of ultrasound in TB. Thank you.
Thank you very much. I'm finding a lot of usefulness in this topic because I have 4% to convince that an ultrasound can be used to diagnose TB. So we can move on. Yeah, so what we are seeing now is an ultrasound. So largely an ultrasound is used to examine the abdominal organs to a large extent. Yeah, so what we are seeing before us is an examination of the liver. And the whitish nodular patches that we are seeing, those are calcifications, and these calcifications were established as a result of TB. So that's a miliary picture. So like I said, what it shows that whenever you see a miliary picture, that in itself denotes widespread TB that is across the entire body. Wherever there's a blood vessel, there's TB there. So it essentially means that every organ is infected now with. So those whitish nodules you are seeing, that's on the liver, and that in itself is due to TB. So to a large extent, an ultrasound can detect acidic fluid, but we know that acidic fluid is not only due to TB. It can be caused by chronic liver disease, it can be caused due to a nephrotic or any hypoalbuminemia process that's going on, and also heart failure. Those are the commonest causes, but TB as well can cause actually acidic fluid to accumulate. And the distinguishing feature or something to look out for is a straw colored. Wherever you find a straw colored ascites, that is likely to be due to TB. Ascites that is clear, you'll see it in heart failure, you'll see it in liver diseases, you see it in kidney problems. And any straw colored in our environment, look out for TB. There's another feature for TB that you should look out for when using an ultrasound. When you see the para-aortic lymph nodes, that in itself defines TB in our setting. Okay, so an ultrasound can be used for TB diagnosis. The other thing that you can actually use an ultrasound for is to examine the heart as well. You could check if there is pericardial effusion around the heart. And if you have excluded heart failure, to a large extent in our setting, that is TB. And TB itself can lead to heart failure when it has caused a cardiac tamponade. Are we together? Great, we can move on. So I'm sure I've convinced the 4% that, and there you are, a miliary TB still, and also an enlarged spleen with some calcifications as well. We can move on. Yeah, so the other issue now, this brings us now to CNS TB. It's also another form of disseminated TB. So the things to look out for are issues of meningeal enhancement, and these are the basal cisterns. I'll show you an image of the basal cisterns that are calcified. Hydrocephalus also is a pathognomic feature of CNS TB. Tuberculomas, though difficult to see, but you could actually have this. In number of settings, you actually have a normal CT brain. But when these features are there, you are most likely dealing with tuberculosis. And if you have basal cisterns that are calcified, you don't even need to struggle, you're dealing with TB. So, and the only way you will know this is using a CT scan or MRI. So that's what you're seeing, that's meningeal enhancement, and that's in the base. So those are the basal cisterns that are calcified. So you will see this on the CT scans and MRI. Even without contrast, you'll be able to see this clearly. Any calcification, you don't need a contrast, but you will see it best with a contrast. The contrast enhances this. Next slide. So that's another calcifications, and that in itself is TB. What you're seeing there, that's a tuberculoma. You can see that it's causing a mass effect. The mediastinum is shifted, and also there's obliteration of the lateral ventricles. So that in itself is causing obstruction. And these patients tend to actually to experience a lot of CNS signs. They may also experience convulsions, and like, if not, they will have headaches that are perpetual. Next slide. So what we are seeing there are outside lateral ventricles. So this is hydrocephalus. So this is due to blocking of the pathways for the flow of CNS fluid. So this is due to TB. That's one of the effects of TB, that it can cause hydrocephalus. Children as well, you can see this. So this you can see in both children as well as adults. To a large extent, this occurs in people who have severe immunosuppression. Next slide. So coming to what we were talking about, the abdominal TB, yeah, I will not dwell much on the idiosyncratic effect and the spleen, but I think what you see commonly is ascites. It can be free ascites, or it can be loculated ascites. Loculated meaning that is just in a pocket, and you may need ultrasound guidance to actually reach that pocket where there is. Abdominal lymphadenopathy, I talked about it, and also you can actually see TB affecting the solid organs, the spleen, the liver, and the like. Next slide. Next slide, let's move on to the next slide. We can also move to the next slide. I think we will not dwell much about this one. Yeah, I wanted you to look at this slide. this is essentially coming from an abdominal X-ray. I don't know if we can get a response from St. Francis. What are we seeing in this slide? St. Francis. Let's see if we have been following. What are we seeing in these slides? Anyone from St. Francis? You've seen where those arrows are pointing? What are we seeing there? Sorry, I've picked you, St. Francis, because you're one of the people I can see. Are you seeing where the arrows are pointing? What is that you're seeing? There are no wrong answers. Give it an attempt. It's actually bilateral. You're able to see it on both sides.
Look like classification.
Yeah.
Francis.
Yeah, they look like classifications though.
The classification, which organ is that? Which organ is that?
The kidneys. That's the adrenal glands.
Excellent, excellent. And actually the slide itself shows so actually. Initially I had not put, then I was compelled to put the title. So I wanted us to interact on this slide. So what you're seeing, these are the left and the right kidney, and you can actually see one of the kidneys above the other. They are all not at the same level. You remember that the kidney, anatomy of the kidney, they are around one is around T9, one of them is around T10, they are about. So what you're seeing, those are the adrenal glands. And like we said, that TB can affect any organ, and this is what we mean. So this is the TB that is affecting the adrenal glands. And you can actually see this in a patient who was presented. Yes, please.
You are breaking. Are you able to free your data maybe by turning off your video if it's on?
Let me do that. Thank you very much, Dr. Chegama. I've taken off my video. Am I clear now?
Still breaking. Let's see if we can follow.
I'm so sorry. Let me try. Tell me when I'm clear.
Better now. Say one more sentence.
Okay. Is this better now?
Much better. Thank you.
Okay, great. I'll get closer to the mic. So you will see this in patients who come with hypertension. They may be severely wasted. They will have hypoglycemia. And what you actually are seeing in those individuals who are wasted, in hypoglycemia and in hypotension, that's an adrenal TB. It's due to the loss of the cortisol function. The corticosteroids are suppressed, and this is individuals during their treatment, you're going to add corticosteroids as part of the treatment. It may be for a short duration, but for life. In this particular individual who has calcified adrenal glands, it may be for life, because that calcification, even with treatment, will not be reversed. So I thought I should share with you the type of patients that you could actually do an abdominal X-ray. So where you suspect adrenal TB, do an abdominal X-ray, and this is what you're likely to see if calcifications are there. So moving on to musculoskeletal. So I'm sure all of us have heard of TB spine, TB of the hips, the knees, and the like. So I have a slide to share with you in the next slide, and also just to mention that 40% of TB that affects the musculoskeletal affects the spine. So Dr. Chegama, let's move to the next slide. And this is what you usually see from the bedside. That's what is on your left, that's what we call a gibbous. And you can actually see that this patient has lost the lumbar lordosis. There is an increased curvature. And looking at the MRI images, what you're seeing, that's a collapsed vertebrae. And that's what leads to formation of what we are calling a gibbous. So this is what you see in TB spine. So there's what we call a kissing lesion. So you have two vertebrae that collapsed and they make it V-shaped, and that's what you appears to be more of a kissing So this defines TB spine. So that's what we want to show for you. So I'm sure you are beginning to realize that HS radiology has a vast role, a big role in TB diagnosis. And we should utilize the tools that we have in our facilities. Next slide. Yeah, so this in itself also just shows musculoskeletal TB, a kissing lesion in the other, and also what you're seeing on the left is these calcifications in the hip joint. So there you may see a restriction of movement. You can see a lot of pain in the hip, and when you do X-ray, you see that calcifications in the joint. That is TB. Next slide. Yeah, so pericardial TB, we've already talked about it, and usually what you see on X-ray is a boot-shaped and enlarged cardiac silhouette. And when you actually do an ultrasound or an echo, what you see there is that you see a lot of effusion. You may have some fibrous strands, and the fibrous strands may tell you that this TB has been there for a long time. So the features to look out for are the fibrous strands and also just an effusion in itself. So that in our environment is TB. If it's hemorrhagic, highly unlikely to be TB, but if it's non-hemorrhagic, that effusion, pericardial effusion, is due to TB. Next slide. So this X-ray just shows us a globular heart shadow. That's what it's showing us. And when you do an ultrasound, make an effort, please, to do an ultrasound or an echo to just confirm that what you are seeing as a globular shadow in the X-ray is indeed an effusion, and from there starts the treatment. So this does not take away history, a good history. So the gap that you are seeing there, this is what you're going to see as an effusion. So you see the heart muscle, you see your diaphragm. So that gap you're seeing there, what Dr. Chengamo, if you can put the cursor where the arrow is, down, yes. That darkish appearance, what you're seeing, that's an effusion. So that's fluid, and that fluid is due to TB. Next slide. Indeed, TB never spares any organ. It can affect the genital-urinary system. We've already talked about the issues of calcifications in the adrenal glands. It can affect the ureters, and also TB can lead to infertility. We have pelvic TB that can lead to infertility when it actually obstructs the fallopian tubes. And that you can see it on some of the imaging, such as CT, as well as MRI. Next slide. Yeah, so essentially those calcifications around the kidneys, you can see it around, they are not stones, but that's the calcifications around the right kidney in a patient. Next slide. So these are some of the IVUs showing the obliterations in the fallopian tube, and you can see a lot of calcifications there. Those calcifications are due to, so you can have TB of the genitals. We have published a case of TB of the testicles, and also there have been cases of TB documented in women. So some of the infertilities that you are seeing is because TB is the cause of that infertility, and treating that TB could help remove the infertility. So TB or not TB, I think radiology still brings, in as much as we've discussed this, challenges still come, and this is where you still need, even if you have radiological features suggestive of TB, you still need to confirm what you are treating or what you intend to treat microbiologically, and you like to subject this, the various specimens to the various platforms that we have, starting with GeneXpert, urine, lamb, culture, and the like. By and large, let's not enter GeneXpert. The GeneXpert may be negative, but the person may have TB. I would like to share with you that the most sensitive diagnostic test that we have is a chest X-ray. Its sensitivity is 98%. Nothing beats a chest X-ray. But its specificity is very low. It's about 60%. So at times it may say it overdiagnoses some cases of TB. So you need to utilize all the tools that you have, and also your clinical acumen should be your guide. So use your clinical acumen, look at the patient before you, is what guides us in TB treatment. This is what I had for you in this session. I thank you. So the take-home message for all of us is that not all cases of TB can be confirmed through microbiological diagnosis. So radiology comes in and helps us diagnose those patients. So the radiology is part and is also key TB diagnostic tool. What is just required is to utilize this tool appropriately. I think as you attain proficiencies in the use of this tool, it is good that you consult colleagues, consult consultants, consult UTH and the tertiary hospitals on some of the images that you have. They will provide a lot of insight into the images that we have. Even me, at my level, when I'm doing a one round, I do consult my colleagues. What do you think of this X-ray? It could be something that I may have missed. So let's all develop that culture of consulting one another. Chair, I submit this is the message that I had for everyone. Thank you.
Thank you, Dr. Lungu. Very comprehensive lecture, and I think we've learned quite a lot from your presentation. Right now, I need to have Choma General get on board so that they prepare to present the case. And as we do that, a reminder of our 4 questions. Certainly, chest X-ray is the cardinal diagnostics tool for TB. You've rightly said it is. And number 2, the chest X-ray is the most sensitive TB diagnostics tool, but with less specificity. That was essentially your closing remarks, and that is true. And an ultrasound has a role in TB diagnosis. Certainly, we saw the images, the ultrasound images that were showing the liver. And I think it is key that we employ radiology in the diagnosis of TB. Thank you very much. Those were the references for Dr. Lungu's presentation. May I hear a word from Choma General as we prepare to put your slides up?
You go to the Zoom. Yeah.
Choma. Dr. Nchimunya, Choma, you had responded earlier.
Hello. Good afternoon.
Hello. Good afternoon.
Okay.
Yes, we hear you loud and clear. Are you able to make your case presentation in 10 minutes?
I will try.
Thank you.
Okay. Good afternoon, everyone. My name is Dr. Miliary TB. I'm a senior resident medical officer based at the MOH clinic here at Choma General Hospital. We can move to start the presentation. Okay, so our case today is a 15-year-old male who's been on MRT since the 17th of March 2011. That was when he was 6 years old. And he's currently on MTT, which was commenced on the 2nd of January 2020. So he's had several regular clinical visits to the hospital since 2011, and he's usually accompanied by the grandmother. and was noted to have had the adherence problems around 2017. So in January of 2020, he presented with symptoms of weight loss and poor appetite for more than 2 months. He had on and off non-productive cough during the same period. However, there was no history of night sweats or a household TB contact. There was no history of being treated for TB in the past, and there was no history of receiving TPT prior to presentation with the symptoms. So he was investigated for the TB. A full blood count was done. A full blood count and the differential count was done. The differential count showed the monocytosis, and the sputum for gene expert was collected, which was negative. The chest X-ray was done as well. It showed the bilateral heterogeneous infiltrates with the high level vaginopathy. Unfortunately, we couldn't test the X-ray for us to share with everyone. So based on this, the child was started on the ATT based on the history, the clinical, and the chest X-ray findings. Okay, move to the next slide. So the nutritional history is that he has 3 meals a day, which usually consists of mushima and whatever vegetable is available. Occasionally, he also has the carpenter. The socio-economic history is that he's a grade 7 pupil. He lives with a grandmother who is 76 years old. The grandmother is the main caregiver. She's unemployed, and their main source of income for the family is a 2-room house, which they rent out for about 100 kwacha per month. Both the parents are deceased. The mother died when the child was 2 years old, and the father died when he was 4 years old. Later on, he was taken out by the aunt, who later sent him to live with the grandmother at the age of 6. This was after he was diagnosed with the TB, and the uncle in the house was uncomfortable with keeping a non-positive child with other children in the house. Can we move to the next slide? So the physical examination, which was done on the 2nd of January 2020, this was at the time of diagnosis with the TB. So the findings were as follows. The general condition was fair. He was tested. He was not pale, no jaundice was diagnosed, and he had no lymphadenopathy. He was noted to have oral thrush, and the anthropometry were as follows. The height was 145 centimeters, the weight was 30.5 kgs, the BMI was 14.4, which is less than -2 standard deviation BMI for age. The BP could not be taken at the time. We didn't have the cuff size for him. The pulse was 78 beats per minute. The temperature was 87.0 degrees. The respiratory rate was 22 breaths per minute. The chest and cardiovascular findings were normal. He was noted to be Turner stage 2 and the WHO clinical stage 2 because of the pulmonary tuberculosis. So the most recent visit that he's had was on the 4th of May 2020. This was the examination finding. So generally, he was noted to be improving. He was not pale, no jaundice, no cyanosis, and he had no lymphadenopathy. The oral cavity was clear. The height remained the same. The weight had improved to 34.5 kgs. His BMI is now 16.4, which is less than -1 standard deviation BMI for age. The BP could not be taken, and let me just say the rest of the findings were normal. Can go to the next slide. Okay, so the clinical timeline and lab results. So the earliest documented result was from the 14th of August 2013, and this was the CD4 count of 904 cells per mil. At this time, the child was started on stavudine, 3TC, and verapine. Then the next result was from the 24th of December 2014, another CD4 count, which was 1,181. At this time, he was on the Apical, Lumidine, and the verapine. I think this was the time when stavudine was phased out. The next result was from the 17th of October 2018. The sample was collected on the 17th of October 2018, and results were received on the 23rd of October 2018. So this was the viral load, the first viral load which was documented, and it was 560,003 copies. At this time, he was on the Apical, Lumidine, and the Valirates. The next documented result was from the 9th of January 2019. That was when it was collected, and the results were received on the 15th of January 2019. So we had the CD4 count, which was now 15 cells per mil, and a viral load of 706,000 copies, 585. At this time, he was enrolled in the ESC and also started on Septrin because of the low CD4 count. So from January, the next result was on the 22nd of July 2019, with results being received on the 31st of July 2019. So here we had an ALT, which was done, documented, which was 3.3, then a creatinine, which was 49.7 micromoles per liter. And the viral load at this time was 277,022 copies. So at this time, the action which was done is that the ES3 was continued, and the client was switched to TDF, 3TC, and reference because the weight was noted to be above 30 kgs. And then the last documented result we have was collected on the 4th of December 2019, with results being received on the 14th of January 2020. The CD4 count had dropped further to 3 cells per mil. The HB at this time was 10.2 grams per deciliter, and the viral load was 396,000 copies. So the action which was taken at this time was to switch to second line, which was AZT, PTC, and DTG. The DTG was being dosed twice a day because the child was on ATT at the same time. Can I move to the next slide? So the problems that we identified with this child were the enormous socioeconomic challenges, and also the moderate malnutrition, post-treatment failure, the pulmonary tuberculosis, and the poor adherence. Okay, next slide. So currently, the status of the child is that the child is clinically improving on the ATT, which is on the continuation phase, and he's completing the ATT this month in June. So the appetite has improved, and he's gaining weight, as we saw, with the latest weight being 34.5 kgs. He's also due for a repeat viral load and CD4 count this same month. Also, efforts have been made to link the child to socioeconomic support through local charitable organization, but we're yet to get concrete feedback. Next slide, please. So our questions today is what could we have done better in the management of this child? And the second one is how could we have diagnosed TB earlier in this child? Then the last one is what can we do now going forward in this child? Thank you very much for your attention.
Thank you very much for that very concise presentation. I wish at this moment to introduce two co-facilitators. There's Dr. Ziambo, I think is in Hub 2, and there is also Dr. Sombo Foloshi. At this time, I would like Dr. Ziambo to take it up as he guides us on the taking of the questions on clarification, as well as the breakout sessions. Dr. Lungu, kindly stay because you will be the expert lead for room 1. Thank you. Dr. Ziambo.
So good afternoon, dear network. Thank you very much, Dr. Chengamwa, for taking us through. Excellent presentation, Dr. Lungu. As always, we appreciate those wonderful presentations. The rest of the network, so you're going to receive a prompting that will come on your screen, and you just follow that link and click on it, and you follow it. It will take you to your breakout session. So we are going to have 3 sessions. One will be led by Dr. Sombo, then one myself, the other by Dr. Njengama. So our IT perhaps could now start giving us that link.
happenings. Thank you so much, Doc.
You're welcome, Isoka. I missed your name, and that's good that Isoka now
Yes,
will be able to.
Dr. Kanku Mutombo, Senior Resident Medical Officer at Isoka
Okay.
District.
Thank you, Doc. I'm sure Dr. Foloshi will be glad to hear the news that Isoka is now joining us. Ian Kafunda, other people on the platform, what do you think on this case? What could we have done better? This is a very interesting case, actually. If you dig quite deeper, what could we have done better for this child?
Hello, good afternoon. This is John Zimba.
Go on, Mr. John.
Yes, this is Vubwi district in Eastern Province, actually. So, what I think would have done better is the issue of, I'm seeing the monitoring part of the patient or the child wasn't done to the satisfaction. Because we only see 2 CD4 count in 2013 to 2014. From that time, we see the next one in 2018. We don't know what was happening in between. And the other thing I'm seeing is maybe we have not been doing well in terms of screening for TB, because by the time the child was noticed to have TB, was severely malnourished. So if we had stuck to those 4 questions that we are using to screen TB, the cough, weight loss, maybe would have the night sweats would have picked this area. So that answers what would have done to diagnose TB area in this child. And even now, I'm seeing the last viral load being done in 2019 December. Up to now, there's nothing that we are seeing. So meaning that this child is still poorly being monitored. As the area speaker said, I think linking the child to OVC may be a very good idea. Maybe they can help the child on maybe supporting the child on the taking of medication. And we really need to push up on the ERK so that we see the child needs to be suppressed. Otherwise, the viral load is very alarming, and I don't think we may achieve what we want to achieve. The other thing which I wanted to say, Dr. Lungu, is that in this case where we are doing a radiological diagnosis of TB, I would have loved with the picture of TB which they got was shown, but it wasn't shown. So, but maybe next time they can do that. Thank you.
Actually, we had actually asked for them to share the extras. I think they received the message quite late. You are very right, Mr. Zimba. And you're spot on that I think the monitoring of the patient, we could have done quite a lot more. This patient went up to wasting. We could have picked the TB much earlier. Possibly gastric lavage could have helped. And also even just sputum collection, because this child is 11 years old, isn't it? So at that age, this child could be able to give sputum. Now I'd like just to talk about the issues of prevention. Could we have prevented TB in this child? What else was missed in the management of this child? This child has been on ART for quite some time. And what we were told is that this child has never received TPT. Is this a child who should have benefited from TPT? Mr. B. Msonda, is it Veronica Msonda? Is this one child that could have benefited from TPT? Is that one area where we didn't do very well? How many do we have here? We have 32 participants, so we should have a lively discussion. I'll pick on Henry Stinga, or Henry Stinga is a co-host. So let me pick on David Singini. Could we have prevented TB if we did? We also have Creso and David take on this question.
Sorry, Dr. Lungu, you're not very clear, but
Are you saying I'm faint?
No, your line is actually breaking, so we can hardly get you, Doc.
Okay, so what I was saying is that could have TPT prevented TB in this child? This child has never received TPT. And from what we've told, this is a child who had vertical transmission of HIV. Did we fall short in providing service to this patient by not giving TPT?
Good afternoon, Dr. Lungu.
Hi, Lucy.
Yes, Doc. Thank you for the presentation. It was very educative. In terms of this child, I think we could have prevented TB by giving this child PTP. And also, just as the other speakers have already mentioned, the follow-up of this child in terms of the transmission, this child was an exposed child. And so the follow-up should have been continuous. I didn't get clearly when the child was put on ART. And at that particular time, even the PTP should have been given to the child to prevent the child from getting TB. Thank you.
Thank you very much, Lucy. You bring in a very interesting point that this child needed TPT much earlier. Others, what are the things that we have missed in this child?
Dr. Lungu.
Yes, please.
If we look at the slide on the screen, and we follow through the ART regimen, we see that this is a child who was on D40-based regimen with nevirapine, went on to ABC with efavirenz. Then EAC was done, then had a single drug substitution where there's only TDF changed, but continues with 3-TC-EFV. I think that time in about this time last year, we also lost an opportunity to actually give him second-line treatment because what we did was just a single drug substitution.
Exactly.
Thank you.
You are very right. I think we could have managed the ART pretty well. So we ended up actually giving this patient possibly monotherapy, and that regimen could have failed this child. And I think it's evident if you look at 4 months later, 5 months later, the viral load went up. So even with that substitution, we didn't have much improvement in the viral load. So we missed quite a lot of to have managed this child pretty better. So now what can we do better for this child? What can we do better? Does this child require another viral load? The last time they did a viral load was in December last year.
There can be any DHO support, whether through HEPS or whatever food supplies that can be given. Apart from that, I think also this child is now an adolescent. I think linking this child to adolescent programs would also be one of the ways of helping this.
Showing is the last one. So I'm sure also from the HB, it will give us a picture of how the child is developing from the treatment.
Exactly, and this child also requires nutritional support as well, isn't it? And it requires a lot of social care. I think those are the things that we need to look at for this child. Indeed, the team has done very well so far. They've started the TB treatment, and I think these are the things that we just have to recommend to them, that they monitor the viral load suppression, they look out for the nutrition. So Dr. Chengam, I think we are good to migrate. We've answered all the three questions.
Dr. Lungu, before you go, I think something very important about adherence counseling, as you on from one relative to another, in future, I think there's need to understand from this case scenario that adherence counseling at every visit is important. Otherwise, it's one of the reasons why things went like that. Exactly.
Dr. Lungu, is this child disclosed to? Any idea?
Is this child?
Disclosure was done or no?
No, we're not sure about it. So perhaps this is a question we can pose to the owners of the patient. I think let's ensure that we keep that question. Dr. Chitembo, also let's keep that question on adherence.
Welcome back, everyone. We've had a lovely discussion, and if we could maybe start with feedback from Dr. Sombo's team. Room 3.
Okay. Hi, Jonathan, Dr. Chengamo. Thank you so much for the wonderful presentation and your excellent facilitation skills. So we have a 15-year-old adolescent who is essentially failing treatment, also on TB treatment based on chest X-ray. Of note is that there are some challenges. Socially, she's being kept by a 76-year-old grandmother. So what could the team have done better? We acknowledge that the team may not have been the ones taking care of this patient, so they may have just met the patient recently. But this child would have benefited from timely enhanced adherence counseling. It stepped in very late. There was poor utilization of viral loads in this case. They could have picked up on the weight loss as an early warning signal that this child was in trouble. This child could have also benefited from isoniazid. This is a missed opportunity because we know, according to the Zambian guidelines, everyone that has not received IPT should receive it. So this child was missed and hence presented with a full-blown TB. We also feel there was delayed switch to appropriate therapy. So, I mean, by the time they're making decisions, you have enough mutations that can not be overcome by a switch. We also feel that they should have recognized quite early in the course that this was an OVC, which is an orphan and vulnerable child. We learned last time that an orphan and vulnerable child is anyone who's HIV infected and is below 17. So this child fell square in that category. That's our opinion on what they would have done better. How would they have picked TB early? As Dr. Lungu mentioned, it may be a very difficult diagnosis to pick, but in children, weight loss is one of the key features that will show up before you actually see a full-blown tuberculosis. The other thing they could have done was a symptom screen at every visit. That's why in our national guidelines, on our ARV forms, everybody must be screened for TB at every visit, so that when you see a flag, you proceed to gene expert or a chest X-ray. The other way they would have noticed it early is when they saw virological failure and low CD4s. The moment you are having virological failure and low CD4 count, you need to intensify your search for opportunistic infections. What can they do for the child now? The good news is that this child is actually at the end of the TB treatment. We hope the child has been taking it. They could go the route of doing an AFB and the chest X-ray to compare the old X-ray to this one and see if there's improvement, which likely there is, as there is already some weight gain. They should proceed and do a viral load. If the viral load is more than 1,000, they need to genotype this child, because we note that there's been sequential monotherapy when they moved from D40 to Abacava to Tenofovir. All that really is switching between drugs that have cross-resistance. So this child may actually fail the dolutegravir, especially if it was not double dose. So they need to genotype this child. They need to link this child to orphan and viable child services. They need a repeat chest X-ray, more nutritional support. They need to engage their community volunteers so that they can further help engage the grandmother. This child needs psychosocial support, and most of all, they will benefit from adolescent care.
Leave some of the things so that we can discuss them also. You just concluded everything now.
Over to your room. I was actually thinking we are not going to present anything. Let's see if you have something new other than what she has ably presented.
Let me say what we discussed. I think most of the things was just maybe perhaps we consider doing dots on the child. That if it's possible, I think that's one idea that perhaps is a bit different. We consider doing dots, and then also going forward, let's build capacity of our frontline staff to be able to follow the guidelines as stipulated in terms of assessing for TB, screening for TB in all patients that are coming. Because if we screen for TB and then we use the chest X-ray, for those that seem to have any one of those symptoms, then it will improve our identification of TB. And so that's the second thing that we thought we really could have added. Of course, ESC, I think we could have introduced it much earlier. In addition to everything else that Team Dr. Sombo have said, I think those are the few things that I could add. And then if the child is in school, we need to find, they need to find a teacher, trusted teacher, who can also support in terms of adherence support. Yeah, thank you, Dr. Ntengamo.
Thank you. Dr. Lungu, in a minute, are you able to add a few things we may have thought of in our room that may have not been mentioned so far? Just what has not been mentioned. Thank you. Dr. Lungu? Okay, maybe we have network issues there. We did talk about nutritional support going forward. We also mentioned that the ESC needs to be relooked at. Is there a need for another relative to come in? Maybe this child is having trouble adhering because it's being kept by the grandmother. And there was also, Dr. Chirembo, what was the question which needed clarification again?
Dr. Ntengamo.
Yes, sir.
At the time you asked me to give what we had discussed in our room, I was unable to unmute myself. Now at least I have access to. So from our discussion in our room, I think most of the things both Kozia and Sombo have alluded to them. But I think one thing that was so striking in this particular patient was that the TB was screaming in the face of the clinicians. So this starts to speak to the index of suspicion. So we need to raise the index of suspicion. A number of things were pointing to that this patient is failing treatment due to OIs, and OIs were in that particular patient as a result of failure of the ART. So we could have diagnosed the patient with TB much earlier. So this speaks to increasing the index of suspicion in all of us. I think that's quite needed. The other issue I'd like just to put emphasis on is TPT. I think this patient should have benefited from TPT way long time ago, and we could have prevented TB in this particular patient. Other striking issues that could have not been mentioned by other speakers, the issue of adherence. And I'm sure you see that this child is an orphan and being looked after by a grandmother. You know the challenges that come with that social setting. So adherence needs to be looked into in this particular patient, even at this point in time. The other issue is that this child is about 15 years old, if I recall correctly. The issue of disclosure of the HIV status. So we need to look into that aspect. It will help quite a lot in managing this child moving forward. Those were the discussion points that we'd like to add, Dr. Chengama. Thank you.
Thank you very much. There is a question Dr. Chilembu had, he had wanted us to clarify. What was it again? I think Dr. Do you recall Dr. Lungu?
Hello, Dr. Chitembo, I think wanted to emphasize on the point of adherence as well as the viral load that the child needed to avail, and those were mentioned by other reviewers. So he was stressing the point of adherence.
Okay, there is a hand from Maureen. Maureen, what do you have to say? Please bring it on board.
Hello?
Yes, Maureen.
Yes,
please
sorry. Yes, I actually wanted to contribute earlier during the group discussion, but what I wanted to say is that probably beyond this, file reviews for pediatric clients that are unsuppressed actually bring out a lot of issues and a lot of things that can be discussed by a larger group. So normally the reviews are done by one person, but if we have a chance of doing file reviews, then we do have an opportunity to have a lot more people looking at the files or looking at how the patients are being managed, just like what was discussed here. So for me, maybe on a bigger picture, maybe just to look at file reviews for all the unsuppressed children at various facilities, it would be very helpful, because a lot of issues actually for individual patients who actually come out. Thank you very much.
Yeah,
All right.
Thank you very much.
So if I may make a comment to that one.
Go ahead, Dr. Ziambo.
Okay, yeah. So I think Dr. Asmanda, that's a brilliant idea, and so I think one of the ambition actually for the pediatric HIV program is to actually make sure that at least every province is having some of these file reviews, and I think we're ensuring that at least every provincial hub has an echo program. And I think going forward, then they will be able to organize in a smaller sort of region and arrange. And this is something that we're discussing with Dr. Chimika as well, Dr. Piri in Southern Province, and I'm sure Northwestern Province, as they get connected in the ECHO, will have that arrangement with Dr. Chengama. So I think it's something that is a good idea, and then we'll really focus it. We'll bring it down to the rest of the provinces as we move forward. Thank you.
Thank you. We are beginning to wind up our session, and I wish to welcome Isoka District Health Office. They had their equipment installed, and the installation was complete. I also wish to mention, thank you very much. Thank you. That Solwezi General also had the equipment installed alongside Mukinge, and I hope by next week they will be online and be part of the network. And to this juncture, I will hand over to Dr. Ziambo for the formalities. But before that, I wish to sincerely thank Dr. Lungu for that wonderful reminder of the importance of radiography in diagnosis of TB, as well as improved clinical acumen at diagnosis of TB. And I also wish to thank Choma General Hospital for coming out clean and presenting what is on file. And our comments are not meant to judge you, but to help each other sharpen our skills. So no harm done to you. This is how we talk in medicine when we're discussing patient care, and it remains in our chat room and we go and implement. Over to you, Dr. Ziambo. Thank you.
Thank you so much, Dr. Chengama. Can we allow just one more hand? I've seen Dr. Judith has got a hand raised. A quick one. Dr. Judith. Okay, all right. Thank you, Network, for having joined us this afternoon. So we just wanted to announce to the provinces, districts out there, that there is a SARS-CoV prevalence study that has been started. I think last week the PS called for a meeting with the various PhDs in the provinces, and we'll have teams coming into the districts next week. Starting next week, I think this week the health promotion teams are coming in. So by next week we'll have the field workers coming in. We are requesting that you may support them. This will happen particularly in Nakonde, Copperbelt, Ndola, Solwezi, Northwestern, and then it will happen also in Livingstone, Southern, and then it will be happening in Lusaka. So we've just sampled the country, and then it's not everywhere. So we will expect our teams coming in. So next week we have another session, and we are looking forward to everyone joining in. We will have a session with Dr. Loti Hachamba, and he will be addressing some issues on advanced care related issues. So it's something that we can look forward to. Let's inform our colleagues to make time and be available for the meeting. Otherwise, thank you so much, everyone. We're very happy that you managed to join in. Dr. Nchengamwa, we appreciate, thank you. All the way from Solwezi, you came in to just come and assist with the facilitation. So everybody have a good day, and we will see you next week.
Thank you so much.
Thank you. Bye-bye.
Thank you.
Thank you. Bye-bye.
Jonathan will send his recommendations to Choma.
Thank you.